Welcome to This Week in Critical Care. This week we're covering 9 notable papers spanning sepsis management and cardiovascular resuscitation, advanced airway and arrest care, and optimization of daily intensive care unit practices, including respiratory support and device safety. Let's dive in. We begin with sepsis care and cardiovascular resuscitation. Mendez and colleagues, writing in the journal Critical Care, published a systematic review and dual frequentist-bayesian meta-analysis evaluating albumin-based fluid resuscitation in adults with septic shock. Analyzing data from 7 trials containing 3,273 patients, they found that albumin-based resuscitation was associated with a statistically significant 10% reduction in the relative risk of all-cause mortality, represented by a risk ratio of 0.90. The Bayesian analysis yielded a 94.7% posterior probability of mortality reduction. While these findings suggest a plausible benefit, the overall evidence is rated as low certainty due to indirectness and imprecision, highlighting the need for larger, targeted trials specifically addressing albumin and septic shock. Next, we explore myocardial injury and sepsis with Lorstad and colleagues, also in Critical Care. This prospective study evaluated 55 patients with sepsis and elevated high-sensitivity troponin T of 15 nanograms per liter or higher, using invasive coronary angiography and thermodilution-based microvascular assessment after clinical stabilization. Coronary microvascular dysfunction was highly prevalent, affecting 61% of patients, and presented as both structural and functional phenotypes. Sepsis patients also demonstrated significantly reduced coronary microvascular vasodilatory capacity compared to matched controls with chronic coronary syndrome. Interestingly, troponin T levels did not correlate with microvascular indices, suggesting that microvascular dysfunction is not the direct driver of troponin release. Crucially, previously unrecognized obstructive coronary artery disease was identified in 22% of these patients, reminding us to consider underlying coronary artery disease in septic patients with myocardial injury. Transitioning to cardiac arrest care, Priebert and colleagues analyzed data from the AFTEROSC-1 and AFTEROSC-2 databases to examine early sedation after the return of spontaneous circulation. Among 1,596 patients, 83% were sedated before intensive care unit admission. Although the early sedation group had a significantly higher rate of favorable 90-day neurological outcomes, 32.4% compared to 11.8%, this difference became non-significant after propensity score adjustment, which yielded an odds ratio of 1.40 with a confidence interval spanning from 0.70 to 2.09. This suggests that the apparent benefit was likely driven by indication bias, where clinicians withheld sedation in the most severely ill patients to facilitate early neurological assessment. Regarding ventilation during resuscitation, Wittig and colleagues published a systematic review in resuscitation comparing volume-controlled mechanical ventilation to manual or other ventilation modes during cardiopulmonary resuscitation. Analyzing data from 2 randomized trials with 120 patients, they found no significant difference in the return of spontaneous circulation between volume-controlled and manual ventilation, with an odds ratio of 1.31 and a wide confidence interval from 0.64 to 2.71. Because the overall certainty of evidence is very low to low, the relative effectiveness of volume-controlled ventilation during cardiac arrest remains uncertain. For patients with acute respiratory failure, Agarwal and Lang, writing in the Annals of Internal Medicine, confirmed that high-flow oxygen therapy does not reduce 28-day mortality compared to standard oxygen therapy in patients with acute hypoxemic respiratory failure. This reinforces that high-flow oxygen benefits are primarily physiological and related to patient comfort rather than survival. When treating patients hospitalized with community-acquired pneumonia, corticosteroids are a key adjunctive therapy, but the ideal dose remains controversial. Yang and colleagues published a network meta-analysis in Critical Care comparing higher dose regimens, defined as a dexamethasone equivalent dose of 7.5 milligrams per day or more, with lower dose regimens of less than 7.5 milligrams per day. Across 32 trials, including over 9,700 patients, both higher dose and lower dose regimens significantly reduced short-term mortality compared to placebo or usual care. However, an indirect comparison showed no clear difference between higher and lower dose regimens, with a risk ratio of 0.98 overall and 1.01 in patients with severe pneumonia. Given that lower dose regimens carry a higher certainty of evidence, these findings suggest no clinical advantage to using higher doses of corticosteroids. In patients already receiving invasive mechanical ventilation, airway clearance techniques are frequently used to manage secretion retention. Rossi and colleagues in critical care reviewed 46 studies involving over 1,800 patients to evaluate techniques like expiratory ribcage compression, mechanical insufflation-exsufflation, and ventilator hyperinflation. While several studies reported greater secretion clearance with these techniques compared to standard care or suctioning alone, these physiological benefits did not translate into clinical improvements. There was no clear impact on mortality, duration of mechanical ventilation, or intensive care unit length of stay. While safe, their clinical utility remains supported only by low-certainty evidence on surrogate outcomes. Turning to daily intensive care unit safety and device management, Martin, writing in the Annals of Internal Medicine, evaluated physical restraint practices in mechanically ventilated patients. The study found that a strategy of low physical restraint use did not differ from high physical restraint use in terms of the number of days patients were free of delirium or coma at 14 days. This suggests that physical restraint minimization can be pursued without adversely affecting cognitive outcomes. Finally, Donner and colleagues published a review in Critical Care on preventing arterial catheter-related bloodstream infections. They emphasized that because arterial lines carry a continuous risk of contamination, a comprehensive prevention strategy must span the catheter's entire life cycle using a bundled approach. Valuable interventions include strict hand hygiene, procedural training, standardized insertion packs, and cutaneous antisepsis with an alcohol-based 2% chlorhexidine solution. For maintenance, they recommend using chlorhexidine-impregnated dressings, changing dressings every 7 days unless soiled, disinfecting access ports, and changing administration sets every 7 days. They note that other practices, including the choice of insertion site and the infectious risk associated with ultrasound guidance, remain controversial and require further research. If you only have time for one paper this week, make it the Systematic Review and Meta-Analysis on Albumin Fluid Resuscitation in Septic Shock by Mendez and colleagues. This paper provides a highly rigorous, dual frequentist-Bayesian analysis of the existing trial data, demonstrating a plausible 10% relative risk reduction in mortality and offering clinicians a strong, quantitative foundation for using albumin in septic shock resuscitation while we wait for definitive, large-scale trials. Here are the key takeaways from this week in critical care. First, albumin-based fluid resuscitation in adults with septic shock is associated with a 10% relative reduction in all-cause mortality, though the current evidence is rated as low certainty. Second, coronary microvascular dysfunction is present in over 60% of patients with sepsis and myocardial injury, but it does not directly correlate with troponin release, and nearly a quarter of these patients have previously unrecognized obstructive coronary artery disease. Third, adjunctive corticosteroids improve survival in community-acquired pneumonia, but higher dose regimens offer no clear survival benefit over lower dose regimens, even in severe cases. Fourth, physical restraint strategies in mechanically ventilated patients do not significantly alter the number of delirium or coma-free days at 14 days. And fifth, preventing arterial catheter infections requires a comprehensive, bundled approach throughout the catheter's life cycle, emphasizing daily stewardship, chlorhexidine alcohol antisepsis, and weekly dressing and administration set changes. That's your roundup for this week in critical care. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.